Uh, Hi, so we will try to study how to read ABG. So before reading ABG, we need to know a little bit about why we do ABG and what all it shows. Basically, ABG is a blood test which helps you quickly see the status of the patient's electrolytes, pH, and oxygenation. So why is the pH important to us? Because it gives us an idea of the acid-base balance going inside the body. The acid part is represented by CO2, which is produced by metabolism and is removed by lungs. This is the fast control. The body can very rapidly control your CO2 levels. The bicarb part represents the base, which is regulated by kidneys, and it is the slower control of the acid-base balance inside the body. So basically, the pH of the report that you see depends on the ratio of CO2 to bicarbonate. Every second, our body is producing acid, that is CO2 is being produced due to metabolism, and if it is not removed, we cannot survive. Why we cannot survive? Because this continuous production of CO2 will lead to acid generation that will decrease your pH, and the enzymes in our body need a range of the pH where they work maximally. If that pH goes below them, the cellular enzyme will stop working. There will be cellular dysfunction, which grossly will lead to organ dysfunction, leading to multi-organ dysfunction, leading to death. So body has a very strict mechanism to control the pH. So the CO2 part, the acid part is controlled by the lungs, and the bicarb part, the base, is controlled by the kidneys. So basically what is the concept is that if you have more CO2, this will lead to more acid generation, so pH will go down. If you have more bicarb, that will be more base, the pH will rise. So you need to remember these normal values. The pH normal range is 7.35 to 7.45. The normal range of PCO2 is 35 to 45, but we take an average of 40 for easier calculations, and bicarb is 22 to 26. Again, for bicarb, we take average value of 24 for ease of calculation. So before you read any ABG report, you have to check whether the ABG report is correct or not, or is there some error in it. Because if you try to interpret any error in this report, it won't lead, it will lead to a wrong diagnosis. So basically, what the ABG machine does is it directly measures your pH and PCO2, but the bicarb is calculated and not measured. That is the reason that sometimes there can be errors, and if the numbers don't fit in the equation, the ABG may be incorrect. It could be due to a mix sample, some entry error, some air bubble inside it, use of too much of heparin. So basically, how can you yourself check for the consistency and whether the report is correct or not? So basically, this is the Henderson-Hasselbalch equation, which gives you the pH. Basically, the thing is that the H plus in your body is in 10 raised to power 4 counts. So it is you cannot do calculations with such large numbers, so that is why we use logarithm. So the pH is equal to 6.1 plus log of bicarb by 0.03 into P. So you check whether the ABG is authentic or not by calculating the pH, and if it is equal to the pH reported, then the ABG is internally consistent. If there is a mismatch, it can be either due to some lab error, some air bubble contamination, a venous sample may be mislabeled as arterial, or some transcription mistake. So basically, obviously, you cannot always calculate logarithms. So you can use approximation in which H plus is you calculate H plus, which is 24 into PCO2 by bicarb. This is a simple equation. Uh, and then you convert that H plus into pH. Roughly, if the pH is 7.4, H plus will be 40. If it is 7.35, H plus will be 35. So basically, if the H plus report matches the pH, then it is consistent and authentic, and you can then read it. Like if for this is just an example. If the in your ABJ report, if the pH is reported at 7.40, PCO2 is 40, bicarb is 24. So with this pH, H plus will be 40. So going to our equation, you uh, uh, put it into the equation we just discussed. Then if H plus comes 40, so this is consistent. It matches and the ABG is valid. So whenever you see a ABG, the first question you have to ask is the patient acidotic or alkalotic? And that is a very simple thing. You just look at the pH. If the pH is below 7.35, it is acidotic. If the pH is more than 7.45, it is basic. That is alkali. So then after this step, you go further down. Then next, you try and figure out what is causing it. Is the lungs causing the acidosis or alkalosis, or is the kidney causing? That is metabolic alkalosis or metabolic acidosis. And a easy way to check it is you check which thing is going in the same direction. So like I said, if the pH is going low, that means it is acidotic. And we just discussed that increase in CO2 is acidotic. So these are going in same direction. Same direction as in both are going towards acidosis. So it is respiratory acidosis. The pH is going low, that is acidosis. The bicarb is going low, that means bicarb low will lead to acidosis, then this is metabolic acidosis. Similarly, you can check for respiratory alkalosis and metabolic alkalosis. Uh, Another way to remember is this, that in respiratory issues, the value, the exact value will be opposite. Like when the pH is low, CO2 is high. When the pH is high, CO2 is low. While in metabolic issues, the trend is same. If the pH is going to the lower side, bicarb is also going to the lower side. So remember, the same direction is not about the actual change in value, but the effect of that value. So again, like for example, if the pH is 7.30, that means this is acidotic. CO2 is 50. Rise in CO2 means acidosis. These are going both in same direction. So it is respiratory acidosis. pH is 7.30, bicarb is 18, it is acidotic, bicarb low, meaning going towards acidotic. So it is metabolic acidosis. So basically, after identifying the pH, whether the pH is towards acidotic or alkalotic side, the next step is determine the cause, which is done by identifying which thing is going towards same direction, CO2 or bicarb. Then the next question, you have checked whether the patient is in acidosis or alkalosis. You have checked what might be causing it. Either it is a lung issue or either it is a kidney issue, that is metabolic issue. Then you have to check, is the body trying to correct it? When the body almost always tries to correct it, matlab if the issue is with the lung, the body will try to correct it with kidney. If the issue is with the kidney, the body will try to correct it with lung. However, if let's say there is some issue with the kidney, however the patient is already ill and the lungs are not in a fine condition, then obviously the patient won't be able to correct it. So even in ideal situation, the body is not able to like correct it fully, but it reaches almost 75%. But if there is a issue with the organ that is supposed to correct it, it might fall far below. So if the issue is with metabolic issue, that is if the issue is with kidney, then lungs will try to compensate. If the issue is with respiratory, that is lungs, then kidney will try to compensate. And you have to also remember that it always goes towards normal. It can never overcompensate. Like if there is respiratory acidosis and kidney tries to compensate, it won't lead to alkalotic side. Okay. So again, if it is metabolic acidosis, pH will be low. Obviously, it is acidosis. It is metabolic, so bicarb will be low. Now lung will compensate by decreasing the CO2 levels. So you need to remember that body never overcompensates. Compensation helps, but it never cures. And if in case you see that the lung is rather than basically if the compensation is going towards the opposite side, then it might signify that it is a mixed disorder and not a simple disorder. So for example, if you see the pH is low, bicarb is low, and CO2 is low. So what does it signify? The pH low, bicarb low, metabolic condition, and CO2 has decreased. So it is respiratory compensation for metabolic acidosis. Next question, if pH is high, CO2 is low, bicarb is low. So low CO2, high pH, low bicarb. So think about it. So if you see the CO2 is low and pH is higher, they are going in opposite direction. So it is a respiratory thing, opposite literal direction. Because high CO2 leads to acidosis, low CO2 leads to alkalosis, like we discussed. So it is a respiratory issue. Now to compensate it, the bicarb is also going low. So it is metabolic compensation of respiratory alkalosis. So now we will first discuss with metabolic acidosis because it is the most chunk, it has most to discuss. So in metabolic acidosis, you will find that the pH is low and the bicarb is also low. Now, why the bicarb will be low? It can only happen in two conditions. Either some acid is added from outside and the bicarb is getting consumed. Example, lactic acidosis, ketoacidosis. This ketoacidosis can be due to diabetes or alcoholic ketoacidosis or starvation ketoacidosis. Or the bicarbonate is being lost. That is, it is being lost either through renal system, the kidney is losing bicarbonate, or you are losing it through the GI tract. That is some diarrhea or another GI issue. So basically, all metabolic acidosis are either there is a gain of an acid or there is loss of bicarb. Now the question is how to differentiate between acid addition and bicarbonate loss. You do it with anion gap. Basically, the formula of anion gap is sodium minus chloride plus bicarb. You can also take potassium in it, but the normal level of sodium is 145 to 155, while the normal value of potassium is 3.5 to 5.5. So it won't yield much. So that is why we almost always ignore potassium. So this is the formula of anion gap. Basically, a cation minus two anions, bicarb and chloride. So that the normal value without potassium is 8 to 12. However, if you are incorporating potassium, the normal value is 12 to 16. So why the normal anion gap? Why basically there is an anion gap in calculation? So you see, the body has to be electrically neutral. The plasma is electrically neutral. So the total cations are always equal to total anions in plasma. But the issue is in machine we don't measure everything. There are unmeasured cations which are calcium, magnesium, and potassium which we are omitting ourselves. And unmeasured anions. The major one is albumin. Other are phosphate, sulfate, organic acid. However, these are low. So in reality, what is the state is that there are measured cations, that is sodium that we see, plus unmeasured cations, and then measured anion, that is bicarb and chloride, plus unmeasured anions, mostly albumin. So anion gap is the gap between this unmeasured anions and unmeasured cations. And normally the unmeasured anions, that is albumin, is far more than the unmeasured cations. So again, in normal physiology, unmeasured anions are more than unmeasured cations. So, and this the largest contributor of this unmeasured anions is albumin. So typically, albumin is contributing to 12 milliequivalents of negative charge, the range of our normal anion gap, 8 to 12. And other anions, phosphate, sulfate, have small contribution, and these unmeasured cations neutralize some of the negative charge, but not enough to bring the gap to zero. So the net effect is that unmeasured anions exceed unmeasured cations by 8 to 12 milliequivalents per liter, and this is what we call anion gap. Now, why it is a range 8 to 12? It is because one different machine have different ions and that can yield different results. Second thing is that varying albumin level. So basically, for albumin, also you have to correct the anion gap because for every decrease in albumin by 1 gram per deciliter, the anion gap will increase by 2.5 milliequivalent per liter. So the formula for corrected anion gap is the calculated anion gap plus 2.5 into 4 minus the lab value of albumin. So why is it necessary? Because if you don't calculate it, you will miss high anion gap metabolic acidosis in a patient with hypoalbuminemia. So it becomes important in critically ill patients like the patients in ICU or patient having a liver disease or nephrotic syndrome. Again, why is it not zero? Because we are not measuring every anion and cation, and the unmeasured anion is more than unmeasured cation. So you have to just remember that plasma is electrically neutral. In actual, like in theory, ions, a positive ion will be equal to negative ion. However, we don't measure everything, so that something else that is hiding is called the anion gap. Now the anion gap can be high or can be normal. If the anion gap is high, that means it is telling that there are unmeasured acid present inside the body that you are not measuring and that is increasing the anion gap. Examples are lactate, ketones, and other toxins like ethylene alcohol. If the anion gap is normal, so there is no hidden acid. Instead, there is loss of bicarbonate that is being replaced by chloride. So our anion gap formula was Na plus minus bicarb minus chloride. So if the amount of bicarb that is being lost is being replaced by chloride, so the anion gap will remain the same. So this is also known as normal anion gap, also known as non-high anion gap metabolic acidosis, or also called hyperchloremic acidosis, because there is increase in the chloride level proportionate to the loss of bicarbonate. So again, it is just summary of what we have discussed, that there are only two possibilities why there can be increase in anion gap, which is some new acid is coming in like lactate or ketones, and that is increasing the anion gap. So now we will discuss about high anion gap metabolic acidosis. So first is lactic acidosis, which is seen in conditions like hypoxia, shock, or sepsis. And why is this? Why is there an increase in anion gap? Because this lactic acid dissociates into H plus and the lactate. The H plus is leading to acidosis, and the lactate is increasing the anion gap because we are not measuring this lactate. So again, lactic acid dissociates into H plus, which is leading to acidosis and is being buffered by bicarbonate, thus decreasing the bicarb, leading to acidosis, and this lactate increasing the unmeasured anion, thus leading to high anion gap metabolic acidosis. Then in ketoacidosis, again example is DKA, alcoholic ketoacidosis, starvation ketoacidosis. There is excess production of acetoacetate and beta hydroxybutyrate. So this ketoacidosis again dissociate into H plus, which consumes bicarbonate, leading to acidosis, and ketoanion, which is an unmeasured anion and thus increases the anion gap. So the key concept of high anion gap metabolic acidosis is that the increase in anion gap is not because of H plus. It is due to accumulation of a conjugate base of the acid like lactate in lactic acidosis and ketoanion in ketoacidosis, along with loss of bicarbonate. So you gain unmeasured organic anion, increasing the anion gap, and the chloride doesn't increase to compensate because there is no loss. It is just being used as a buffer. So the gap widens. So you just have to remember that high anion gap means acid is added. Normal anion gap means a loss of bicarbonate that is being uh, compensated by increase in chloride. There is this also famous formula, just to remember that examples of high anion gap are methanol, uremia, propylene glycol, isoniazid ethylene glycol, or antifreeze salicylates. These are added toxins. Other than this, lactic acidosis, DK, and of normal anion gap are renal tubular acidosis, uh, use of spironolactone, use of carbonic anhydrase inhibitors, and saline administration, formation of fistula, ureterogastric conduit, or diarrhea, that is GI loss. So, for example, if you see that the sodium is 140, chloride is 100, bicarb is 10, you calculate the anion gap, it comes out to be 30. It means high anion gap. So that means acid or a toxin is being added, and it is being disassociated into a H plus ion that is being buffered by the bicarb and into its anion, that is increasing this anion gap. Now in another example, Na140, Cl115, bicarb 15, so the anion gap comes to be 10. So this is normal anion gap. That means there is loss of bicarbonate that is being compensated by increase in chloride. Then once you have figured out that the patient has metabolic acidosis, you have calculated the anion gap and figured out that it is high anion gap or normal anion gap, then you check is the body compensating appropriately, and you do it with a formula which is known as Winter's formula. So how you do is that you check whether the value match with what you calculate. If they match, then the body is compensating. If it is not matching, either it is partial compensation due to some damage to the organ that is supposed to compensate, or there is also a presence of second disorder. So the formula is that the expected PaCO2 is equal to 1.5 into bicarbonate plus 8 plus minus 2. If by this formula the calculated PaCO2 level is equal to the PaCO2 you are seeing in the blood gas report, then it is appropriate compensation. If CO2 is more than expected, it means either the compensation is not enough or there is respiratory acidosis. If CO2 is less than expected, that means too much compensation, and this doesn't happen physiologically, so respiratory alkalosis is also present. So for example, if bicarb is 10, Then expected CO2 is 1.5 into 10 plus 8 plus minus 2. So 23 plus minus 2, 21 to 25 is the expected PaCO2. If it is 24, it means normal compensation. If it is 35, that is too high. Then partial compensation, or patient also has respiratory acidosis. If it is too low, then body never overcompensates. It is respiratory alkalosis. Now, in case of a high anion gap metabolic acidosis, how do we identify if multiple metabolic problems are occurring together? You check the delta gap to detect mixed metabolic disorders. So, delta gap is used to unmask mixed metabolic disorders. What is delta gap? Gap is basically you check how much acid was added and how much bicarbonate fell. That is calculation of delta anion gap. Whatever is the anion gap, you subtract 12 from it, and whatever is the bicarb, you subtract that from 24, and then you check. Again, you can only have to use delta gap. That is the gap between the change in anion gap minus change in bicarb, only when there is high anion gap metabolic acidosis. Because it is in this delta gap concept, we are assuming that there is rise in unmeasured anions, and that should be balanced by fall in bicarbonate. That is why we are checking the gap. It doesn't apply in normal anion gap metabolic acidosis. Because in normal anion gap metabolic acidosis, the drop in bicarb is being compensated by increasing chloride, that is hyperchloremic metabolic acidosis. So there is no gap to analyze, no change, no expected fall of bicarb for the rise in anion gap. So delta gap becomes meaningless. Rather, in this we use urinary anion gap, which we will discuss later. So understanding the delta gap. So first we have cleared that the patient has high anion gap metabolic acidosis. Now you have to check whether the rise in anion gap is equal to fall in bicarbonate. If it is equal, approximately equal, then it is just pure high anion gap acidosis. In case the change in anion gap is more than the fall in bicarbonate, then it means that the bicarb has not fallen enough, indicating that there is metabolic alkalosis also. The reason why bicarb is still high. And let's say if the change in anion gap is less than the change in bicarbonate, that means the bicarb has fallen too much. That means it is also trying to cover something else. That will be normal anion gap acidosis. So if it is approximately equal, just high anion gap metabolic acidosis. If bicarb is more than anion gap, that means there is metabolic alkalosis. If it is less than the change in anion gap, that means there is also normal anion gap acidosis. So basically, mismatch either suggests a metabolic alkalosis or a normal anion gap acidosis. So if we see through example, if the anion gap is 28 and bicarb is 10, the change in anion gap is 16, the change in bicarb is 14, so it is roughly equal. So it is a pure case of high anion gap metabolic acidosis. Now if anion gap is 30, bicarb is 20, change in anion gap will be 18, change in bicarbonate will be 4. Now the bicarb has fallen much higher than the rise in anion gap, indicating there is metabolic alkalosis. Similarly, either like we just discussed delta gap, we can check delta ratio. That is the change in anion gap divided by change in bicarb. If it comes between 1 to 2, it is pure high anion gap metabolic acidosis. If it is less than 1, that is there is the change in bicarb is more than the change in anion gap. It indicates there is normal anion gap acidosis also. And if it is more than 2, that is the change in anion gap is far more than the change in bicarbonate. That means there is also metabolic alkalosis. So basically, if we have to summarize, first step is not this. There is also a step 0. That is, you first check whether the report is consistent or not. The report is valid or not. Then you check the pH, whether the patient is acidotic or alkalotic. Then you check the cause by checking the CO2 and bicarb values. Then you check for compensation. Then you check if for anion gap. If it is high anion gap, you check for delta gap to make sure it is not a mixed disorder. For example, if you see a ABG and you have checked that it is valid, now see the pH, it is towards the acidotic side. Now though CO2 is low, bicarb is low. That CO2 is in opposite direction, bicarb is in same direction, or like I said, in metabolic conditions, they will go in same. Fall in pH, fall in CO2, fall in bicarb, so it is a metabolic issue. The CO2 is decreased, so there is compensation. Then you calculate the anion gap, it is high anion gap, you check the delta gap to check for any mixed disorder. Now urine anion gap. Basically, we use urine anion gap in a normal anion gap metabolic acidosis to differentiate between renal versus extrarenal cause. Basically, urinary anion gap tells that either the kidney is responding appropriately or not. You calculate urinary anion gap by adding sodium plus potassium of urine minus chloride. This is a surrogate of NH4 plus excretion. Why? Because what is this anion gap representing? This anion gap is representing the NH4 plus which we are not able to calculate, which is the reason why there is a gap. Because this NH4 plus is being excreted with chloride. However, we cannot directly measure it. So this chloride is a surrogate marker of the NH4 plus excretion. Let's say if there is negative urinary anion gap, that means there is high NH4 plus that we couldn't measure, indicating there is high chloride in urine. So kidneys are working properly. This indicates a extra renal loss. If it is a positive urinary anion gap, that indicates there is low chloride, meaning there is low NH4 plus. So the kidney is not doing proper ammoniogenesis and not excreting the H plus NH4 plus, meaning the kidney is failing. Then it indicates renal problem, that is renal tubular acidosis. So summary, in case of acidosis in normal anion gap, the kidney should increase the NH4 plus excretion. That will be seen as increased chloride because it is a surrogate marker of NH4 plus. If you see that there is high chloride, basically the urine anion gap is negative, then it is a non-renal cause. And if the chloride is low, that means the urinary anion gap is positive. That means a renal loss and renal cause. Just remember that a negative urinary anion gap indicates kidney is doing its job. UAG is checked in non-anionic gap metabolic acidosis, and delta gap is for high anion gap metabolic acidosis. Now we'll see respiratory disorders. So remember, basically the body has three buffers. The one are the buffers present inside the blood. That is the bicarbonate, hemoglobin, the proteins inside the cell phosphate. These buffers act within second. However, they are not changing any actual change in the value of the base or the acid. They are just at for that time combining with the excess acid or excess base to neutralize the value so that the body can function immediately. Then there is respiratory control of pH, which acts like the buffers in the blood act within second. Respiratory system acts within minutes, and the last it's the kidney, which takes hour to a day to act. So the CO2 changes are immediate within minutes. However, bicarbonate, that is the change that is to be done by the kidney, is slow. So what it indicates that in case you find in a patient that the bicarbonate has changed significantly, that is a proxy indicator that it is a chronic issue and the kidney has already had the time to adjust to it. So first we will see respiratory acidosis. So basically in respiratory acidosis, it is acidosis, so CO2 will increase. Now, if it is acute acidosis, there will be less increase in bicarbonate to compensate for it. If it is chronic acidosis, there will be more change in bicarbonate to compensate for it. So the compensation rule for acute respiratory acidosis is +1 change in bicarbonate for every +10 addition of CO2. And for chronic is +4 addition of bicarbonate for every +10 change in CO2. That is, if CO2 increases by 20 in acute acidosis, bicarb will increase by 2. However, in the same case, if there is increase by 20 of CO2 in a chronic case, bicarb will increase by 8. Now, respiratory alkalosis, respiratory issue leading to alkalosis, that is CO2 will be low. Again, it can be acute or chronic. In acute, the fall in bicarb for every 10 CO2 will be 2, and for every 10 CO2 will be 4 if it is a chronic condition. So basically, if you have to remember that the chronic change in both acidosis and alkalosis is same. The bicarb changes by a value of 4 as per the addition or subtraction of CO2 from your blood. However, it differs for acidosis and alkalosis. For respiratory acidosis, the shift in bicarb is by 1, and for alkalosis, it is 2. So you can remember that SID is one step away from becoming second boyfriend of Alka, where SID was acid and 1, and Alka is alkalosis and it meant 2 if you didn't get it. So for example, let's say that in you see a ABG and you see the CO2 is 60. So the normal value is 40, the net change is by 20. And the bicarb is 26. Normal value is 24, net change is by 2, indicating a acute condition. Another case, CO2 is 60, bicarb is 32. The net change in CO2 is by 20. Bicarb is 24. Normally, the rate change is by 8, indicating a chronic issue. So, for a chronic respiratory acidosis, bicarb changes by 4. For acute respiratory acidosis, bicarb changes by 1. SID is one step away. So now these are just some examples. When do you have a respiratory acidosis? When you will have CO2 retention like CNS depression due to opioid sedatives, obstruction of airway in COPD, severe asthma, neuromuscular issue, GBS, myasthenia, chest wall anatomical disorders like kyphoscoliosis or severe lung disease, late ARDS and pulmonary edema. However, early ARDS leads to increased respiratory rate and tachypnea. So it leads to CO2 washout. So early ARDS leads to respiratory alkalosis, late ARDS leads to respiratory acidosis. Now examples of respiratory alkalosis, that is CO2 washout. If it is due to hypoxemia driven, the body is stimulating more respiration as it senses hypoxemia, like in a condition of pneumonia, high altitude pulmonary embolism, or due to CNS stimulation, anxiety, panic, pain, head injury. In hormonal pregnancy, progesterone increases respiratory drive. Drugs like salicylate, early salicylate toxicity leads to tachypnea, leading to respiratory alkalosis. Then systemic illness like sepsis, liver failure, or iatrogenic if you overventilate a patient. Then we have seen how to read a ABG, what happens in metabolic acidosis, what happens in respiratory acidosis and respiratory alkalosis. Uh, Metabolic alkalosis we will see later on. Now, apart from this, in ABG, another thing you see is oxygenation. That is the other half of ABG. You see the PaO2, which is normal at room air 80 to 100. If PaO2 is less than this, that indicates hypoxemia. Now, why will be the O2 low? Either it can be again due to hypoventilation, due to CNS depression, high altitude neuromuscular disease. In all these conditions, CO2 will rise, O2 will decrease, or due to VQ match, like in pneumonia or COPD. VQ mismatch in ventilation and perfusion. Then, due to shunts, blood bypasses the lungs, so it cannot be oxygenated, or severe ARDS, or diffusion problem like in ILD. Now, when you see the PaO2, you have to calculate the AA gradient. AA gradient is the difference between alveolar O2 and arterial O2. The normal AA gradient is 5 to 15 millimeters of mercury. If the AA gradient is normal, that means the issue that the patient is having is hypoventilation. That is, there is no issue with the lungs, but the patient is hypoventilating. However, if there is a gap between the alveolar A2 and the blood gas O2, and which is more than 15, that indicates a lung pathology like a VQ mismatch, a shunt, or a diffusion defect. How do you calculate this? So basically, PaO2, this PaO2 you will get in your ABG itself. But the alveolar O2, you have to calculate. The formula for alveolar O2 is you check the FiO2. If the patient is on room air, it will be 21%. Otherwise, it will be whatever oxygen support you are giving to the patient. Multiply it with the subtraction of atmospheric pressure minus the pressure of water, which is whole subtracted from PaCO2 by R. R is 0.8, usual number. So again, FiO2 is 0.21, Pa atmosphere 760, pH2 47. So if you put the fixed values, it comes to 150 minus PaCO2 by 0.8 if the patient is on room air. So if the patient is on room air and you have taken a ABG at room air, you calculate the AA gradient through this formula and then check it. If it is within normal range, then it is a hypoventilation issue. If it is more than the normal range, then it is a lung pathology. Apart from this, the thing is that we just said it is a range 5 to 15. So you need to have one single value to correctly read it. So you calculate it by taking the age of the patient, dividing it by 4, then adding 4 into it. For a 20-year-old patient, the normal AA gradient is 9, and for a 60-year-old patient, the normal AA gradient is 19. So basically, as the age increases, the normal value of AA gradient increases. Now we will study metabolic alkalosis. So if it is alkalosis, that means the pH is high. Metabolic, that means there is issue with bicarb. The increase in bicarb will lead to alkalosis. So the question is, why is bicarb high? It can either be due to a loss of acid, such as vomiting, leading to loss of HCl, suction by NG tube, which will leaving behind bicarb, or gain of alkali, like antacids or excess bicarbonate infusion or some other source. One example of metabolic alkalosis is contraction alkalosis, which is seen when you use a loop diuretic or a thiazide diuretic. Basically, what happens is when you give them, there is loss of salt and water from the kidney, leading to contraction of ECF volume, and that leads to metabolic alkalosis. How it happens, we will see. So basically, first you give the diuretic that will disrupt the gradient in the kidney, leading to diuresis and natriuresis, that is loss of salt and water, leading to a shrinkage of plasma volume. That is what we mean by contraction. Now you are losing fluid without proportionate loss of bicarbonate. That leads to a non-physiological increase in bicarbonate, leading to alkalosis. This is one mechanism. Apart from this, as you are losing salt and water and there is contraction of plasma, there is activation of RAS. Now this RAS will lead to increased aldosterone, and this aldosterone causes reabsorption of sodium and increased secretion of H plus and K plus. This increased secretion of H plus will also add on to this alkalosis and worsens it. Then also, if you are losing potassium, that will lead to hypokalemia. Hypokalemia further worsens the alkalosis. Then the most important point is the loss of chloride. To excrete bicarb, you need to remember this point, that for the excretion of bicarb, you need HCO3, because the channel the body uses to maintain the electrical neutrality is bicarb chloride exchanger. So if you are losing chloride, then the body will have low resources of chloride, and there will be no chloride to exchange bicarb for it, leading to defective excretion of bicarb. So the four reasons why you have contraction alkalosis: contraction is due to decrease in plasma volume, then because of disproportionate loss of water as compared to bicarb, then aldosterone activation leading to H plus secretion, then hypokalemia, and then depletion of chloride. So in metabolic alkalosis, now the most important clinical step is to you check urinary chloride. Now the cutoff number is 20. If the urinary chloride is less than 20, then it signifies two cause. Either it is due to vomiting, where all the chloride is being lost as HCl, or it is post diuretic phase, where the chloride has already been lost in the urine as NaCl. So body doesn't have enough chloride to excrete. Now these both conditions will lead to metabolic alkalosis, that is saline responsive. Now in case the chloride is more than 20, that means that the body has reserves for chloride and it is actively secreting or losing chloride. Now it can happen in two conditions, either hyperaldosteronism or Cushing's. Why does it happen? It is because there is ongoing Na plus retention due to either increased steroid, whether it is aldosterone or glucocorticoid, and that leads to loss of potassium and hydrogen. And to maintain the neutrality, there is also loss of chloride. So what you need to remember is that if you have low urinary chloride, give saline and it will respond to it. The metabolic alkalosis will improve. If the urinary chloride is more than 20, that means there is some hormonal issue leading to this metabolic alkalosis. So the concept, what all we discussed, it is that the metabolic alkalosis persists only if kidney cannot excrete bicarbonate. And the kidney's ability to excrete bicarbonate depends on the availability of chloride along with the volume status, because RAS controls aldosterone, which controls H plus. So if you check urinary chloride, it tells you whether the kidney is trying to hold on to chloride. Means either is the body volume depleted or not. If the body is trying to hold chloride, that means it is depleted with volume, and that is why the urinary chloride will be low if the body is trying to conserve it, and that is why it is saline responsive. However, if the kidney is not trying to conserve chloride, that means there is no true depletion of volume, and it is happening due to overactivation of channels and receptors, that is hyperaldosteronism. Or so if we have to see in depth, now let's see that there was a patient of metabolic alkalosis. You check the urinary chloride levels, they came out to be low, indicating that it is a chloride depleted state or a saline responsive state. Now what does it indicate? That the body has lost chloride and volume and the kidney is trying to conserve chloride, thus the urinary chloride is low. So what is happening physiologically? There is loss of chloride in some form, either it is lost as NaCl due to diuresis and natriuresis, or HCl due to vomiting, and along with loss of volume, which is activating RAS. What is happening at the kidney? The kidney, to increase the volume as water follows sodium, tries to reabsorb sodium, but there is the chloride is lost, so body absorbs sodium with bicarbonate to maintain electrical neutrality and excretes H plus, which worsens alkalosis. And there is no chloride for the kidney to excrete bicarb. To mean again, the channel is bicarb chloride exchanger, and there is no chloride, so body cannot excrete bicarb. Body rather is absorbing bicarb to absorb sodium, leading to alkalosis, and body is losing H plus ions. This happens at the beta intercalated cell. There is a channel chloride bicarb exchanger, which is also known as pendrin. The chloride goes inside the cell and bicarb goes into urine. But for this channel, you need adequate source of chloride. If there is no chloride, there will be no exchange, bicarb stays in blood, alkalosis persists. Once you give saline, there will be increase in volume, turning of RAS, turning of aldosterone, turning of hypokalemia, turning of loss of H plus, and chloride will go into the pendrin channel in the beta cell and allow bicarbonate excretion, and the alkalosis will start to correct. Now, if the urinary chloride is more than 20, then it indicates that the kidney is not trying to conserve chloride, or the body is chloride resistant. Then the urinary chloride is staying high. So the problem is mineralocorticoid effect. Either it could be due to aldosterone or some glucocorticoid like in Cushing's. This mineralocorticoid is causing increased Na plus reabsorption with loss of potassium and hydrogen, which generates metabolic alkalosis. Now saline won't help because already the body is pathologically storing sodium, so volume is already expended. The RAS is not the main issue. The RAS excess is not pathologically being activated that you can correct by increasing volume. Rather, there is continuous persistent excess hormone, which is the actual problem. So giving saline won't fix this alkalosis. So, in summary, if urinary chloride low indicates the depletion of volume and chloride, the kidney is trying to conserve chloride, RAS is activated, you treat with saline, which gives chloride for the excretion of bicarb and stops the RAS. If urinary chloride is high, it indicates hormonal issue. And kidney is wasting chloride, there is no primary driver, that is RAS, and the treatment is treating the cause. Like in winter, there is also a winter formula for expected CO2 in metabolic alkalosis. In metabolic acidosis, we saw, if you can remember, that the expected PaCO2 was 1.5 into bicarb plus 8 plus minus 2. So for metabolic alkalosis, the expected CO2 is bicarb plus 15 plus minus 5. Now we will see some concept in depth. If you see in a VBG report or a ABG report that the pH is normal, that does not mean that the patient is in normal physiology. It can mean that either the body has fully compensated the issue to maintain the pH in a normal range so that it can function properly, or it is a mixed disorder where there is this spuriously normal value of pH. So example of mixed or compensatory causes like first sepsis. In sepsis, you can have pH near normal with low bicarb and low CO2. But does it indicate pH is low, bicarb is low? That means it is a metabolic issue. So it is a sepsis, there is metabolic acidosis, and there is decrease in CO2 to compensate for it. The metabolic acidosis is due to lactate buildup because of tissue hypoxia. So it can have a normal, near normal pH, but it is not because the body is in normal physiology. So even if you see a normal pH, you have to always check the bicarb and CO2 levels. Now in diabetic ketoacidosis, pH will be low because it is a metabolic issue. Bicarb will be low, and there will be compensatory decrease in CO2, which is a compensatory mechanism to bring back the pH to a normal value. It is not a cure, but a temporary measure so that the enzymes in the body and the physiological process in the body can go smoothly. Then the third example is COPD, which is a chronic respiratory acidotic condition. So there will be persistent high levels of CO2. And because it is a chronic condition, the kidney will get adjusted to it and the change in bicarb will be more. Like we saw that in acute respiratory acidosis, it was change of 1 for every change of 10 CO2. But in chronic, it is change of 4 for every change of 10 CO2. So it might bring the pH to near normal, but it is respiratory acidosis compensated by metabolic alkalosis. Then salicylate poisoning, as we discussed, that it causes tachypnea. leading to washout of CO2, and it also causes acidosis, and it dissociates into a cation and an anion which consumes bicarbonate, so the pH can be variable. So you will see respiratory alkalosis and metabolic acidosis. So it is a mixed disorder. Now there is this concept of base excess and base deficit. It is a simple thing. You see this on the ABG report itself, and it is, you have to remember that it is independent of CO2. This just gives you an idea of the metabolic parameter. So it has nothing to do with the CO2 levels, but to give you an idea of the metabolic state of the body. If the base excess is positive, it indicates that there is too much base. So the body has metabolic alkalosis. If the base excess is negative, that indicates that there is too little base. So there is metabolic acidosis. So again, base excess is just an indicator of the metabolic state of the body. If it is positive, it points out towards alkalosis. If it is negative, it indicates towards metabolic acidosis. The only advantage is that it gives you a rapid, rough idea about the metabolic state of the patient, and it is independent of CO2. So basically, if you have to see what is base excess is the amount of acid or base needed to bring blood pH back to 7.40 at normal PaCO2. This is only in the definition, but in the report, it is independent of PaCO2. So if there is negative base excess, that it indicates there is metabolic acidosis. If it is positive base excess, that is the amount of base you require to bring pH back, that means it is alkalosis. -2 to +2 is normal. If it is within this range, that means the body is in a metabolically normal state. However, if it is in negative, it indicates acidosis. If it is positive, more than this +2, it is alkalosis. You can, this, the machine gives it, but just for the sake of completion, this is calculated by Sigurd-Anderson equation, and this is the equation, and this is what the machine uses, because it knows the pH, it calculates the bicarb, then the machine puts these values in the motherboard or whatever the chip it uses and gives you a value. You just have to check whether it is less than -2 or if it is more than +2 to see the metabolic state independent of PCO2. Just remember, it gives you a rough rapid idea about the metabolic state independent of PaCO2, and if someone asks you the definition, then it is the amount of base or acid required to bring blood pH back at normal PaCO2. So it helps. Why is it useful again? It is independent of CO2, can be used even if the CO2 is abnormal. You want to isolate the metabolic disturbance, or you can want to check the serial. You have serial reports of ABG and you want to see the progression, whether the disease is worsening or getting better. So this is just an interpretation table. Let's say if the patient has pH is low, that means there is acidosis. The PaCO2 has increased and the base excess is normal. That means there is no metabolic issue. Then it is pure respiratory acidosis. Now, if pH is high, PaCO2 is low. This is happening in reverse. The CO2 is going down, pH is increasing. That means it is a respiratory component. Base excess normal. Then it is pure respiratory alkalosis. Now, in the same scenario, if the base excess is low, that is, it is negative. That means there is metabolic acidosis also present along with it. And in this same respiratory alkalosis scenario, if it is positive, then it indicates there is both respiratory alkalosis and metabolic alkalosis. Now, let's say if the PaCO2 is normal and the base excess is low, pH is low, it indicates pure metabolic acidosis. If both are high, indicates pure metabolic alkalosis. If pH is low, PaCO2 is low, base excess is low, pH and PaCO2 going in same direction, indicating a metabolic issue. So it is metabolic acidosis. Base excess is also representing the same. And this decrease in PaCO2 is for compensation. And the reverse happens in metabolic alkalosis. Hope you got it. Now there is this concept of osmolar gap. It is not seen in the ABG report, but it is always taught with that. So we will also discuss this. The osmolar gap helps you to see any toxin even before they cause the damage. The toxins we are talking about are methanol, ethylene glycol, and alcohol. So basically, you use this osmolar gap in a patient with altered sensorium, metabolic acidosis, with a history of consumption of any illicit substance. So the thing is that the anion gap alone may be early poisoning, because the gap will only increase once these toxins disassociate into their anions and cations. And those anions or cations are responsible for the damage. It is the metabolism of these substances that leads to toxic products that are causing the change in the anion gap that are also leading to disease. So in case if a patient comes early and you suspect them, you can check a smaller gap far before they are started to cause any toxicity. So again, limitation of anion gap, that anion gap rises only after the toxin has been converted into the acid. So in early stage, anion gap can be normal. You can miss the diagnosis, so you can check the smaller gap, which checks the unmeasured osmoles in blood and it sees the toxin. How do you calculate the osmolar gap? The formula is 2 into the sodium level plus glucose divided by 18 plus 1 divided by 2.8. So you can calculate the osmolality and you get send the blood osmolality to the lab and then you divide them, the measured osmolality from the calculated one. If it is less than 10, it means it is normal osmolar gap. That means there is no toxin present. However, if it is high, that indicates there are presence of unmeasured small molecules, which are methyl and methylene glycol alcohol. So in toto, if a patient comes in a state where these toxin substances have been started to metabolize, so that patient will have the toxin and their metabolites leading to high osmolar gap and high anion gap. But if he comes very early, then the anion gap will be normal, but the osmolar gap will be increased. If he comes very late, the osmolar gap might start to come back to normal, or that is less than 10, but the anion gap will be still be high. So basically, if you see a patient with falling osmolar gap and increasing anion gap, that indicates that the toxin is being metabolized and is continuously causing damage to the body. Then we will see a little bit about lactate. So what is lactate? Lactate is a product of anaerobic metabolism. Basically, when pyruvate cannot be metabolized aerobically, it gets converted into lactate. The normal value is less than 2 millimole per liter. So again, normally pyruvate goes into mitochondria. There is aerobic metabolism. However, if there is some decrease in oxygen or mitochondrial dysfunction, this pyruvate will get converted into lactate. But you need to remember that lactate is not always equal to hypoxia. Lactate is just a marker of cellular stress. It can also happen in conditions where there is no hypoxia. And also that it is the trend of lactate that is more important than just a single value. So again, lactic acidosis can be of two types, type A and type B. Type A is seen in hypoxic conditions where there is cellular hypoxia leading to anaerobic metabolism. Example is shock, sepsis, cardiac failure, carbon monoxide poisoning. And in sepsis, you can have adequate oxygen, but despite that, there can be lactic acidosis that is because of mitochondrial dysfunction. Then type B is non-hypoxic. Example is liver failure, malignancy, drugs like metformin, isoniazid, and cyanide poisoning. There is cellular dysfunction, but no hypoxia. Then again, we just saw that how chloride is very important for excretion of bicarb due to presence of chloride bicarb exchanger in the beta intercalated cell. So we will see a bit more about it. So the thing is, we always study that normal saline is neutral. However, that is not the reality. It is a myth. Normal saline can cause acidosis. How does normal saline lead to acidosis? Basically, again, the body has to be always electrically neutral. So if you give too much of NaCl to someone, that will lead to increased chloride in the levels. To compensate for that increased negative charge, something must decrease. That something is bicarb. So any rise in chloride has to be compensated by any fall in bicarbonate. So this hyperchloremia will decrease the strong ion difference. We will see what is a strong ion difference or SID that will lead to decreased pH, leading to hyperchloremic metabolic acidosis. So again, if there is increase in chloride, compensatory decrease in bicarb must occur. This bicarb decrease in bicarb leads to metabolic acidosis. So you gave someone a high amount of saline, the chloride level rose to 154. This NS doesn't contain any bicarb, so it will lead to increase in decrease in bicarb, increase in chloride, leading to hyperchloremic metabolic acidosis. Other examples, as we discussed in earlier slides, are diarrhea and renal tubular acidosis. Another thing with issue with this hyperchloremia is that it also decreases renal blood flow. Why? Because this high chloride will go through the kidney. There will be increased delivery of this high chloride to macula densa. It will sense it as increased GFR. And then there will be tubuloglomerular feedback that will cause constriction of efferent arteriole, decreasing renal blood flow, decreasing GFR. So this is the another issue with using too high amounts of NaCl. So again, why does this matter clinically? If you give large amount of saline, that will lead to hyperchloremia, that will decrease kidney perfusion and can increase the risk of AKI. Now the thing is strong ion difference, as we saw that how chloride decreases the strong ion difference. So basically, strong ion difference is the difference between the major anion and the major cation. The major cation is sodium, the major anion is chloride, and the normal value of this is 40. What is it representing? The SID, the strong ion difference, is representing the balance of the strong positive and the negative ions, with the strong positive ion is sodium and the strong negative ion is chloride. Now, why will this affect pH? So again, remember that the body must maintain electron neutrality, and there is always, it is in a state of equilibrium. Every reaction is that is reversible is happening in a equilibrium. Now let's say if the anion gap decreases, so either it can happen due to increase in chloride or decrease in sodium. So effectively what it signifies is that there is more major negative charge in the plasma. To compensate for this, body has to increase H plus, which will cause fall in pH leading to acidosis. Similarly, if strong ion difference increases, that is either due to decrease in chloride or due to increase in sodium, then that means that there is more positive charge in the plasma, major charge. So there will be decrease in H plus. So it will lead to alkalosis. Now a little bit about ABG and ventilator, what to change when. So if you see a ABG of a ventilate patient who is on invasive ventilator support, the CO2 is a proxy indicator of ventilation and O2 is a proxy indicator of oxygenation. So CO2 basically is reflecting the alveolar ventilation. So PaCO2 is proportional to the CO2 that is being produced in the body divided by alveolar ventilation. If CO2 is high, that is indicating that there is hypoventilation. So how will you fix it? By either increasing respiratory rate or by increasing tidal volume. However, you cannot increase tidal volume to much more than 6 ml or 7 ml per kg because it will lead to barotrauma. If CO2 is low, that means there is too much of washout, you decrease the respiratory rate, you decrease the tidal volume. So again, when there is increase in CO2, you increase respiratory rate first because increasing in tidal volume can lead to baro or volutrauma. Now PaO2 is reflecting the oxygen transfer. If PaO2 is low, that indicates the oxygenation failure. So the quick temporary fix is increasing the fraction of oxygen you are being provided and to increase the alveolar recruitment, that is increasing the P. In case CO2 is normal but O2 is low, that means the issue ventilation is normal. So the issue is at the lung level. It could be due to a shunt, due to ARDS, due to ILD, diffusion problem, or VQ mismatch. So again, FiO2 will increase the immediate oxygen delivery and PEEP will recruit alveoli. But you cannot use high FiO2 because it will lead to oxygen toxicity. So you use PEEP to reduce FiO2. But again, you cannot increase PEEP too much because that can lead to pressure trauma. So what do you do in a ARDS patient? You do two things. First, you use low tidal volume to prevent barotrauma. Second thing, to protect the lungs. Because you are using low tidal volume, you allow permissive hypercapnia. So your aim is not to normalize CO2, but to protect the lungs and to keep the PEEP high so that you can recruit the alveoli. Now, few final concepts. Does it matter if you get a VBG or ABG? Not unless you are checking pH or CO2, because the change in pH is as low as 0.03 and the change in CO2 is only 4 to 5 mm. You only need ABG if you want to check the O2 status, that is the PaO2 status. Then what can be the possible spurious errors in ABG? One, there can be air bubble inside the syringe that will lead to diffusion of CO2, decreasing the CO2 levels and increase in O2. So giving a false respiratory alkalosis with good oxygenation. If there is delay in processing, the cells might consume all the O2, produce CO2, leading to respiratory acidosis. If there is too much of dilution, it can decrease the bicarbonate, leading to metabolic acidosis. Acid-base situation with special conditions in pregnancy, progesterone stimulates ventilation, leading to CO2 washout, which will lead to respiratory alkalosis, which will be compensated by kidney by increasing excretion of bicarb. In high altitude, hypoxia stimulates ventilation, leading to CO2 washout, which is later compensated by kidney. In CLD, again, there is increased respiratory drive. Now, as we talked earlier, that there are three systems to maintain your pH. One is the immediate buffer system, then the lungs, then the kidney. So the immediate buffer system preventing the pH to crash immediately. The main buffers are bicarb, hemoglobin, protein, and phosphate. So any H plus that is added, its buffer absorbs it and maintains the pH and buy the time for lung or the kidney to act. Now, one important buffer system is ammonia buffer system. Basically, in PCT, there is motamine metabolism and there is formation of ammonia. Now, this ammonia combines with H plus and gets converted into NH4 plus. This is a very major buffer that helps in excretion of H plus ion, proton, acid, and it allows a very large amount of H plus to be excreted. Now, and it is central to compensation of metabolic acidosis where kidney then tries to excrete H plus as possible. Now, the clinical link is, let's say if there is some issue and you cannot form ammonia, like in type 4 RTA, this decreased NH3 formation, ammonia genesis, will prevent the kidney to excrete this H plus, which will lead to acidosis.